Our next presentation is Transversus Abdominis Plain Block versus Local Wound Infiltration for Elective Minimally Invasive Cholecystectomy in Children and Adolescents, a prospective randomized trial by Dr. Sinhu Manava.
Good morning. We have no disclosures. Pain control after surgery in pediatric patients typically includes a multimodal approach with a combination of opioid and non-opioid medications. In addition to pharmacologic therapy, injectable analgesia is another critical aspect of a multimodal regimen and may include transversus abdominis plain or TAP block or local injection of analgesia at incisions. While TAP blocks are safely performed in children, there is limited data on this topic in the pediatric literature. Minimally invasive cholecystectomy is a common procedure performed in the overall healthy pediatric patient population. Given the gap in the literature and the frequency of this procedure, we sought to study the efficacy of TAP block versus local infiltration of anesthetic in patients undergoing this operation. In this study, we hypothesized that TAP block would be superior in controlling postoperative pain when compared to local infiltration. We performed a randomized controlled trial comparing these two methods of analgesia in patients operated on by 9 pediatric surgeons at our institution. We included patients from 8 to 17 years of age who were undergoing elective operations. We excluded patients with a history of chronic pain, BMI greater than 50, or acute indication for surgery. Patients were randomized in a 1-to-1 allocation ratio to either ultrasound-guided bilateral TAP block or surgeon-administered local wound infiltration at the time of port insertion. In both cases, a total of 2.5 milligrams per kilogram of 0.2% ropivacaine was used. A maximum dose of 60 milliliters was allowed. A sham TAP block dressing was used for patients who underwent local infiltration. All patients received a standardized approach to pain and nausea control both intra and post-operatively, as shown in this figure. In the OR, they received fentanyl boluses titrated according to heart rate increase, and prior to extubation, they received IV ondansetron, hydromorphone, and ketorolac. After arrival to PACU, nurses performed routine pain score assessments every 10 minutes and documented this in the chart. IV hydromorphone was given in the PACU for pain scores greater than 6 out of 10. Finally, after arrival to the floor, pain scores were administered every 4 hours. Patients received IV scheduled ketorolac, oral acetaminophen, and daily polyethylene glycol. They also had as-needed opioid medications available, including oral oxycodone and IV hydromorphone. At the time of discharge, patients were sent home with oral pain medications according to their inpatient needs immediately prior to discharge. We performed phone call follow-up 24 to 72 hours post-discharge to inquire about pain medication use and symptoms. We performed this study over 6 years. While 477 cholecystectomies were performed during this time period by our surgeons, ultimately 85 patients were consented and enrolled in this trial, with 42 patients in the TAP block arm and 43 patients in the local infiltration arm. All patients were included in analysis, and 32 patients were included in each arm for follow-up. There were no significant differences between TAP block and local groups in terms of age, gender, BMI, diagnosis, or surgery type. There were no significant differences in length of stay, total time in the operating room, total time under anesthesia, total procedure length, or PACU maximum pain score. The time from anesthesia start to procedure start was significantly longer in the TAP block group, despite no difference in total OR time. In terms of post-discharge outcomes, there were no differences in follow-up pain score, pain medication use after discharge, total opioid dose used at follow-up, or abdominal pain. After controlling for sex, age, and surgery type, there was no significant difference in total OR time, pain score at follow-up, or post-discharge constipation or abdominal pain. Our trial had the following limitations. The enrollment was relatively low despite a prolonged study period. This can be attributed in part to enrollment pause during the early months of the COVID-19 pandemic. Additionally, patients were approached for recruitment in the preoperative area rather than a few weeks prior in the clinic, where they may have been more amenable to enrolling in a trial. 2 patients in each arm of the study were given discharge pain medications that deviated from the protocol, and these patients were not excluded from analysis. In conclusion, we found that there are no differences between TAP block and local anesthetic in terms of total time in the operating room, postoperative opioid use, and GI symptoms. Patients who underwent TAP block spent a significantly longer time under anesthesia prior to procedure start. Our takeaway from these results is that the decision to proceed with TAP block versus local infiltration should be discussed between the patient, the surgeon, and the anesthesia team. In a scenario where delays may occur while waiting for staff or equipment to perform a TAP block, local anesthetic can be given with equal results. I'm happy to take any questions.
This abstract's open for discussion.
Yeah, I commend you for doing this type of study, and certainly during the pandemic, it would be very hard. So regarding the patients who didn't enroll, what was the default to that? And do you have any information, at least up to discharge? Obviously, you can't call them. I think that might strengthen your work and see if there was any difference in that, because it's such a large group. Was that group different that didn't get, would really strengthen your conclusions?
Thank you for that question. There is no default in terms of what patients receive. So if patients who were not enrolled in the trial, it was up to, if the anesthesiologist was interested in offering a TAP block, then that conversation was had between the anesthesia team and the patient. And if they were not, then the default would be that the surgeon would perform the local anesthetic.
I had a question. In choosing this procedure, a laparoscopic cholecystectomy, was there any consideration for a procedure with a longer postoperative stay where opiates might have a bigger impact, like an ileocystectomy, where you might be able to see a difference in some of the measures that you looked for?
Yeah, thank you for that question. The trial started well before my time from when I was involved in this project, so I was not involved in the initial discussions, but that is another interesting patient population that we could consider studying this in.
We have a virtual question.
Hi, yes, another virtual question. Did you look at hospital anesthesia charge difference between TAP block and local?
Thank you for that question. We did not look at a cost analysis between the different patients that we studied.
Question?
Hi, Oliver Solis, Dayton Children's Hospital. So the TAP block doesn't cover the right upper quadrant very well, and a better block for that would be, because 3 of your ports in your diagram are in the right upper quadrant. So a TAP block maybe is not the best one. A quadratus lumborum block, QL block may be better because it's more posterior, or a rectus sheath block. So I'm wondering if that's maybe the reason your study doesn't have as much of a positive outcome as you'd like.
Yeah, thank you.
Question?
Given that the main finding here is that there's no difference, I'm curious what the study was powered to find, just so we can kind of confirm. So did we do a power analysis or an evaluation to make sure we were powered to conclude that there are no differences between the two groups?
Yeah, we did perform a power analysis. In order to reach adequate power, we would have had to enroll more patients than were enrolled in this trial. So that was another one of the weaknesses, certainly.
Okay. Thank you.